This week on the Back Table podcast.
Not everybody has to be involved. Donate money, donate time. You get pretty good within your wheelhouse at your clinical skills. The first 3 to 5 years you're out, you're busy figuring things out. You're probably going to be overwhelmed by the idea of needing to be involved in advocacy and politics. Not necessarily, but I certainly was. This is not necessarily something you will intersect with at every point in your career, but the idea is that the degree to which you may be involved and how you may be involved and the opportunity to be involved may change at year 5, year 10, year 15, as well as, sort of what you can offer to the conversation over that time. Really encouraging people not to sort of decide to go all or none. This is really something you can kind of come and go from.
Hello, everyone, and welcome back to the Back Table podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsor.
Fellow provides mail-in semen analysis for clinics looking for improved compliance and a patient-friendly solution to vasectomy and fertility testing. Their CLIA certified lab combines the ease of a mail-in semen analysis with peer-reviewed clinical performance to provide reliable results in less than 2 business days. Fellows testing dramatically improves the experience for patients and clinic staff, achieving compliance rates of up to 95% compared to published rates of 30 to 50%. Here's a couple data points. Urology of St. Louis has tested over 3,000 patients with Fellow, and their compliance rate increased by 62%. And the VA Boston saw a 119% increase in compliance for post-vasectomy testing with Fellow. To learn more about Fellow's vasectomy and fertility testing, visit meetfellow.com. That's MEETFELLOW.com.
Now, back to the show. This is Aditya Bagrodia as your host this week, and I'm excited to introduce our guests today, Josh Langston and Mara Holton. Josh and Mara are intimately involved in healthcare policy and business within LUGPA, the Large Urology Group Practice Association. They've been on the show a couple times now, at least Mara has, and I thought it was a tremendous episode. Really looking forward to picking your brains on kind of where we are, where we're going, and what can we do instead of sitting by as innocent bystanders as healthcare changes. So welcome to the show, Josh, Mara. How are y'all doing today?
Great. Thank you so much for having us.
Great. Thanks for having us.
Yeah, it's a pleasure. I got to share a little story. It's such a small world. Josh and I were actually in the same class interviewing for urology residencies and overlapped at UT Southwestern a long, long time ago. And it was just amazing as these podcasts kind of started coming up in conjunction with LUGPA that he was looped in. And I was like, oh my gosh, what a small world. So great to see you again, Josh. Mara, great to have you back on the show.
Yeah, thanks for having me back. I got my 5 minutes of fame after our last podcast. I got several text messages. So thank you for that.
Hey, those are the ones that keep you coming back, right?
That's right.
And we do go way back, Aditya. And so I was watching from afar as you launched this and just so proud to see it. And so amazed that somebody I knew was doing something this cool. And then one day I got the call to be a part of this. And I can't tell you, I'm like, guys, this is a big deal. This is a big deal that we get to do this. So it's great to be on, but so cool what you've been able to do for our field with putting this together.
Absolutely.
Well, thanks, Josh. So today it's kind of a broad topic. It's the business of healthcare, it's advocacy, it's the evolution of healthcare. And before we just jump into it, healthcare, what are we actually talking about here? It seems like such an all-encompassing term.
Yeah, so it really has become something that has snowballed into a massive part of our economy, right? So $4.5 trillion getting spent every year in America on what is considered healthcare. So that's covering everything from inpatient care and outpatient care that maybe we're more familiar with, obviously, to the pharmaceuticals, medical device, durable medical equipment, and all of the home care and other services that patients need, especially as they age. And really is shocking that somehow that comes out to $4.5 trillion, isn't it?
It is shocking. And maybe I'll take a moment just to share a story. And this is not necessarily representative of the whole healthcare. When we were kids, we would go to India for the whole summer, and it was amazing. And if and when things popped up, as they invariably did, we'd call the doctor. We'd go in to see them, usually within 24 to 48 hours. They'd order whatever tests. You'd go get an x-ray or some lab work. Out-of-pocket costs were probably $50 to $100. You received a prescription. You went and paid for it at the pharmacy, maybe $10, $20. And that kind of was the healthcare experience for that acute episode. Maybe, Mara, I'll ask you to compare and contrast that to somebody in the United States who took a tumble and you're worried a little bit about something going on.
Yeah, I mean, I think it's a pretty salient observation. So even when I was a child, and that was many, many, many years ago now, but, my parents would take me to the pediatrician, and there was a lot of sort of that straightforward visiting a provider, writing a check for a service received. And the paradigm has changed tremendously in the last many decades. I won't say how many because I don't want to age myself here, but it's been a while. So I think, to your point, the experience of people typically now when they intersect with healthcare is that they really have no idea sort of where the costs are coming from, who's involved in generating costs. You get a bill from a lab, a bill from a hospital, a bill from an anesthesia group. And so Josh referenced that giant 4.5 trillion number, but even on the individual basis, patients are sort of increasingly perplexed and confused about who they're paying and what they're paying for.
My secretary, her daughter had to have open heart surgery right after birth, and it's been a year and a half. They haven't received a bill. I said, how much did that end up costing you? She said, we don't even really know yet. We can't even get them to tell us. And it's also interesting, we use this term insurance. And if you think about what insurance means in every other part of your life, it's this thing that's like a backup, a safety net in case something bad happens. You have to fall back on that. But otherwise, you consider the costs and expenses and you pay for things, as you said, you pay for the service you receive. And so really, we've veered far off of the original intent of insurance, I think, as we look at what healthcare insurance looks like versus other aspects of our lives where we have insurance.
Yeah, I use the phrase, it's paying for something that you hope you'll never use. And, I taught sharing examples. We had our bladder cancer meeting, which we have every Thursday. We're very excited to have Adstiladrin, a new medication for refractory non-muscle invasive bladder cancer. And this is what actually happened. Is wild. We had a patient, perfect candidate, all that, came in for his installation. Something had slipped through the cracks. His out-of-pocket was going to be $20,000. And here's the incredible part. And understandably, he was like, I can't afford that. And the medication was wasted. And fortunately, the powers that be are rectifying this scenario. But if you think about that example, now this is a complex cancer medication. There's the patient who ostensibly called UC San Diego to get a second opinion, was evaluated, insurance made sure that they were approved in their work, et cetera, was prescribed to get this drug, had to get all that sorted out with, again, insurance, pharmacy, the doctor's office, if you will. And here we are. And I think it just highlights the complexity of it. And maybe doctor, patient, medication, procedure, labs, imaging is like a super simplified way to think about the actual services delivered. But there's way, way more people into it. When I think about it, there's a lot of people involved. And it seems like the number of people involved is growing exponentially year over year. Can you maybe comment on that?
So we have a word for that involvement. It's rent seekers, and they're all of the people involved in the delivery of healthcare who don't necessarily add value to the ability of the provider to deliver a high quality service and the patient to receive a high quality service. I think Josh's point was really interesting. It's sort of a misnomer. We don't use health insurance as insurance. We use it as sort of a prepaid, as you alluded to. But then for a variety of reasons, including regulatory complexity of care. You referenced a very complex patient. There are any number of people who you have to interface with in order to receive that care, e.g. a specialty pharmacy in Wisconsin, who is the only place in America that makes that medication. And then the shipper, who's the only person who's authorized to ship that medication. And then you have all sorts of regulatory guidelines about how you can receive that medication. And then ultimately, all of those sort of inputs notwithstanding, you end up putting a $20,000 medication in the trash, which is just, really sort of the ultimate tragedy. The patient doesn't receive it. The system loses the value. So I can complain a lot. The complexity of the system is what it is. Care has gotten a lot more complicated, but I think you're absolutely right. We really do need to be evaluating the system for where there's opportunity for value and to give better value to patients and to make physicians better able to give care to their patients.
Yeah, people are really familiar with a chart that circulated around that shows the growth of hospital administrators over the last 20 or 30 years versus the growth of physicians, right? And so there's been this like 3,000% increase in quote unquote hospital administrators. But to Mara's point, it's the system that has created that. It's really the government regulation and expectations that have created the need for all these roles. But then the government provides the funding to support that, right? So why have we become this massive bloated bureaucracy? If there wasn't the funding to hire people to do these jobs, they wouldn't get hired. So the funding is coming in from the government, what they see as a necessary degree of regulatory individuals at every step along the way and reporting and documenting all sorts of things that we do. And of course, I think probably started with very good intent, but has really spiraled out of control. Probably we'd all agree.
Yeah, I think actually that goes a little bit to sort of value-based care. So we look at, or there's an attempt and been a lot of conversations since the Obama reforms about assessing the efficacy and value of care. But I think there hasn't been enough scrutiny on the value of these regulatory sort of covenants that govern how we deliver care and whether they're actually delivering the value that they're supposed to, which is better care, more expedient care, more quality care, those sorts of things.
I hear you. And I think you're being nice, actually, both of you, that the cost of healthcare, the number of players involved is maybe due to increased regulatory environments, but also think that there's just this huge pie out there that people want a piece of it. And I get the sense that there's been an evolution in terms of leadership involvement of physicians within their practice, as opposed to people that really don't understand this somewhat unique service that we provide. We hear about private equity. We hear, again, you talked about administrators, 3,000% growth. Like, I don't think that's all to like address regulatory burden. I think it's like there's $4.5 trillion out there. How do we get a piece of that? And I guess the question would be, can you talk a little bit about the evolution or loss of a leadership role of physicians, if you see it as such?
I'll jump in kind of first and just talk a little bit about what I'm doing. I just have recently taken over for our group as managing partner and CEO, and we have about 50 providers, about 300 employees, so fair-sized business. Also run our ASC in addition to the group. So there's a lot to it, and I think that it is absolutely, to me, essential to have an understanding of the subject matter of which I'm managing, right? Meaning being a physician, understanding those details. So, I mean, Mara has been doing it longer than me in a similar role, and she can speak to this. But it's interesting because when my IT team comes to me and says, hey, we need this or that switch or this or that, whatever, I have no clue what they're talking about. And I realize that's how hospital administrators are when people come and talk about the provision of healthcare, right? They don't actually know that they don't have any background, any real innate knowledge of that for the purposes of decision making. So, I mean, I think it's a tragedy, and I think we would all agree that we don't have physicians in more positions. And I think one thing that I've heard mentioned in a talk, and I'd love to credit who said it, but I can't remember, is a really interesting thought that physicians are the only profession. And if you think about professionals, whether that be lawyers, engineers, the other examples were even the clergy and I think the military, you would never fathom having a leader of any of those industries that wasn't a member of that profession. How many law firms are run by lawyers? Engineering firms are run by engineers. You'd never have a pope that wasn't once a priest. Well, but hey, that's not their expertise. Their expertise isn't running large organizations. It's being an engineer, it's being a lawyer, it's being a priest. But there's still an understanding that you need somebody that inherently understands and is of that profession to be at the top of that pyramid. And yet in healthcare and in medicine, we as physicians, we've relinquished that. And last thing I'll say is something that will always stick with me. When I was a resident, I was getting involved in a lot of this stuff. And I say this to encourage trainees and young docs to get involved. But one of my co-residents, he said very sincerely, he said, I don't get it. Why are you wasting your time doing a residency, training as a doctor? If you really care a lot about business, why don't you just go do that? And I said, no, man, you don't get it. We have to have people that can live in both worlds, that can talk both languages, And that's the only way that we're ever going to really succeed here. So I think if there is a sentiment among us that we ought to just stick to what we know, stick to taking care of patients and leave the rest to others, we've kind of seen how that's turned out. And so I think where folks like Mara have been leading the way in how to lead an organization well as a physician.
Thank you. And also resonate a number of the comments that you made. I think that the other thing that is unique, what really spoke to me was when you talked about a pope who hadn't been a priest. So it's a special relationship, presumably, between a parishioner and their leadership. And I think that most people think that's the most important portion of that relationship. So that is why you select from the clergy to lead the clergy. But somehow in medicine, the doctor-patient relationship isn't the most relevant or the most pivotal criteria. It's the business of medicine that somehow doctors are too, not smart enough or too busy to attend to, in addition to that sort of most important relationship, which is obviously the provision of care to their patients. And I think that's a really great point, Josh, because we would never assume that the Pope can't run the clergy because he's so focused on the spiritual needs of his flock. Why can't we take care of our patients and run our businesses?
One other thought there was somebody brought me a flyer for a conference a few years back, and it was called Health. The subtitle was The Future of Healthcare. And I thought, well, the future of healthcare, I guess I should probably know about this. And so I ended up going to the conference. It was in Vegas, so that didn't hurt. And I was very interested. I was fairly new in practice. I was, very interested in leadership and policy. And so I thought this will be great. I'm sure there'll be a lot of like-minded folks. We'll all learn about what the future of healthcare is going to be. And it turned out, the best I could tell from the very large attendance at this conference, I was the only physician, other than physicians that were employed by the companies that were presenting. And so there was the CEO of CVS, and there was a bunch of other thinkers and angel investors and these sorts of folks. And not to disparage them, the fact that there were no other physicians there after walking around for 3 days, I didn't see a single one, was really shocking. I mean, we're talking about ostensibly the future of healthcare, and there's no doctors in the room. So fascinating.
Well, I think there's so many things, again, that kind of go into this. Maybe you all are both employed in large group practices, and I get the sense that that's something important and meaningful to you. We've seen trends in private practices, solo practices, large group practices, hospital employment, and that seems to me something front and center, maybe driven by COVID in some form or fashion. But can you talk a little bit about this general shift of employment of physicians from private groups, community groups, et cetera, to the hospital? And why does that matter, and how does that impact things?
So there's been a massive shift. This is not news to anyone. There's been a massive shift of employed physicians from what we would call a traditionally independent setting. And you referenced a little bit that the definition of that may be variable from place to place, but essentially non-hospital employed. So Josh and I are both in large single specialty groups, although we may have a practitioner of a different type or sort. But in general, we're both in big GU groups. So hospital employment subsumes now more than 50% of providers or physicians in essentially all specialties. That's not truly across the board, but those statistics have been increasing over the years. They've sort of stabilized a bit in the last year or two, but COVID created a lot of messiness in the statistics, so nobody really knows what that means. But clearly, physicians are choosing to work for large hospital entities as employed physicians. And I think what Josh was referencing that we're both incredibly excited about, and when he was talking about that resident who he spoke to those many years ago, is really being able to determine both our own destinies, the destinies of our clinical practice, so to have decision-making about how we practice medicine, and also decision-making surrounding, care of patients. So obviously, I'm not implying that in a hospital setting, people don't have decision-making surrounding care of patients. Of course, that's not the case. But the priorities of my practice, for example, may be different than the priorities of Josh's practice because the group of physicians comes together and decides that our community has a different set of needs or we have a different focus as a practice. And that's a ship that's fairly easy to turn because there are 30 of us. We're all urologists. We talk about it. I shouldn't imply that we're herding cats, but we can come to a consensus. Refocusing a hospital who has much more complex priorities as to services to the community, those sorts of things, their focus is never going to be as myopic as purely GU. So to some extent, we have the luxury of really focusing on what we think we need to do to deliver better care to our unique patient population.
I love that. It makes perfect sense.
Yeah, that was really well said. I think the consolidation that we're seeing, it certainly accelerated through COVID. And I think data that's a little bit old now from a little over a year ago would say that about 75% of all doctors across the board are now employed. But it's part of a larger consolidation that is happening where now hospitals aren't independent either. They're consolidating into larger and larger health systems. They're employing now large portions of physicians. And so it's not just physicians that are consolidating. And I think you may have seen the headlines recently that now Optum, which is part of United Healthcare, has now become the single largest employer of physicians in the U.S. with over 70,000 doctors now working for an insurance company. And so that's another interesting aspect of all this.
Interesting is a word.
Well, it is interesting. So I grew up in East Tennessee, rural East Tennessee. And I don't think that there was a lot of healthcare systems that were interested in really kind of putting up together massive infrastructure where I grew up. And this is something that kind of really honestly shocked me. I feel a bit embarrassed that I didn't really appreciate the workforce shortage issues, the issues surrounding urbanization. But does this kind of maybe transition from independent practitioners to hospital employed, does this impact workforce shortages? Does this lead to further disparities? And could you comment a bit on that?
So I think we all know that, so Josh referenced the tremendous growth in hospital administrators and the declination of providers. So clearly we are seeing there be more infrastructure and less people actually able to deliver services. And what you reference is the health inequity in rurality, which is becoming extraordinarily more magnified in these situations as these systems coalesce. So, sort of I don't know what your life was like in rural Tennessee, but I'm going to assume there was a internist who maybe there was one person in the office, maybe two providers, a GP or a family provider. And those sorts of practices literally can't exist anymore. Nonetheless, you're absolutely right. The return on investment from a giant hospital system to make some giant infrastructure investment in rural Tennessee is probably still pretty marginal. So we really are getting to a place where the system was very dependent on the willingness and the interest of this group of people who were practicing in largely independent settings, particularly in rural settings. And as that winnows down, to Josh's point, to less than 25%, we're seeing the workforce shortages everywhere are much more acute in rural areas. And that creates access and exacerbates health inequity.
Yeah, I think it's fascinating that a generation ago, there were urologists, even specialists like urologists, that would go to a smaller, medium-sized town and be happy with a career there. And I think that as those folks retire, it's clear that they're not going to be replaceable. Most urology groups are hiring, and everyone would say that they're struggling to find as many docs as they would want, even for very desirable metropolitan areas, much less rural areas. But, to your point about how consolidation affects this, without getting too much into the policy side, hospitals are able to bill at higher rates for services when they're performed on campus, so to speak. And so two things that come from that. Number one, if a doctor sells to a hospital, they're probably going to have to relocate their practice potentially to a hospital campus, which is more likely to be in a more urban location. And then there are studies that show that the work product, the amount of work done by physicians when they go from independent practice into employed practice goes down. And because the billing is so much higher per work unit, for instance. And so those are two factors that really impact rural America significantly. And that's one of our messages of the value of independent practice, because it is independent practices that are more likely to be in those areas. And an interesting political angle on that is, since the makeup of the House of Representatives is based on population, and population is centered around more populous metropolitan areas, there really isn't a good representation of rural America. There aren't that many people who represent these lower density populated regions. And so it makes policy actually harder in DC.
Yeah, it's hard to advocate for those patient populations because they don't have a tremendous amount of representation. So it's really a crisis.
Yeah, I think the AUA really did a good job at the Advocacy Summit bringing this front and center, in my opinion. If there was one statistic that is seared into my brain from here on out, it's that 62% of counties in the United States don't have a urologist. And that's a shocking statistic. And of course, okay, maybe counties are close or far or this or that, but however you analyze it, I think it's still just highlights this. And of course, it's multifactorial. I mean, I think there's this urbanization, metropolitanization is just part and parcel of upcoming generations. But these infrastructure market dynamics, I don't think are helping at all. So what you mentioned, Josh, was it's just kind of a odd thing to think about. I think we all know this. Depending on where care is delivered, there's going to be different amounts of reimbursement and so forth. And I think the one thing that's the most obvious thing is that the costs of healthcare continue to rise. We're currently at about a $4.5 trillion nugget. First off, who's paying for it? Who's paying for this increase in cost?
Mostly you. So taxpayers are paying for it. Obviously, the largest burden of healthcare costs are in the Medicare budget. And so we're all paying for that. And then those of us who are privately insured are seeing it in our premiums and our copays. So both the cost of healthcare has gone up and the burden borne individually by both the privately insured and sort of the populace at large has increased alongside it.
All right. So Medicare, Medi-Cal, kind of government-run subsidies, that's everybody's paying for it. Then I think, Mara, you're saying patients are paying for it.
Yep. So the portion of, as care has increased, the patients, not just percentage-wise, but the patient's proportion of the cost of that care has also increased.
I think to the tune of about 10% per year increase year over year for the patient's out-of-pocket burden.
All right. So patients are paying for it. And I think this is also something we need to kind of dig in on. So there's this, okay, does it matter? Does it actually impact patients if the costs go up?
So I don't like to pay more for the same or less. And, there are a whole variety of untoward consequences of the cost of healthcare going up. I think one thing that, maybe we don't want to highlight on this podcast, but we're obliged to, is that life expectancy and QOL initiatives for Americans have gone down over that interval. So when you benchmark us against other countries, we actually are spending more on healthcare, and many of our markers or indices show that we're receiving lower quality care, or at the very least having poorer outcomes overall. So more expensive, poorer outcomes. That's certainly not anybody's goal.
Yeah, I absolutely think that's what we should talk about. If I can pay more to be healthier and happier and get better outcomes, sign me up. But I think I'm hearing that these increasing costs are not translating into better outcomes very broadly. Is that true?
I think if you look at, everybody loves to pick on United, but I think it's just a good example. So, they're spitting out 20 plus billion in profit every year. And so they come to the physicians and they say, hey, times are really tough and economic indicators suggest that we're going to have to lower our payments to you 3% this year. And then they flip around to the beneficiary and they say, hey, inflation's really hitting, everything's more expensive, we're going to have to raise your rates. So they cut the rate to the physician, they raise the rate to the consumer, and they keep the margin on that, which is why, gosh, I wish I would have bought their stock about 10 years ago. But in reality, patients are paying more and they realize that. And so they're expecting a product commensurate with that, which, we're struggling to be able to provide in light of the ever decreasing funding that we're receiving for the services we provide.
So I think you actually hit on a bunch of things there, all of which are really candidly crises. So, Josh talked about the fact that we see the reimbursement to physicians going down every year. So if you look at that in real dollars from 2001 to 2024, doctors are actually getting paid 30% less in spite of inflation, presumably, which occurred during that time. So that's pretty remarkable for equivalent services. And that's in the physician fee schedule. Aditya, you referenced the fact that there are site of service differentials, and this is an incredibly important thing to highlight and really goes alongside Josh's comments about hospital consolidation. So there have been any number of changes in the way things are paid that have really promoted these hospitals consolidating into these large systems. And one of them is this thing called a site of service differential, where the exact same procedure is reimbursed at a much higher rate in what's called an HOPD or a hospital outpatient setting, and a much higher rate in an inpatient setting. So those have promoted both the misuse of higher level settings, so tertiary care facilities for procedures that probably don't need to be subsumed in tertiary care facilities, as well as then providing these sort of slush funds to acquire physician practices, which then through a variety of sort of complex legal wrangling, become these higher site of service values despite the fact that it's the same doctors providing the same care, oftentimes in the exact same location where they were before, but reimbursed at these much higher rates. So we know there's a tremendous amount of waste in the system and a lot of really perverse incentives to deliver care in ways which are not cost efficient.
Okay, Aditya, I'm going to put you on the spot to tag on to that. So a prostate biopsy in my office, Medicare costs about $230. So what's the cost if it's done in a hospital side of service?
$500.
$1,800. So the difference between the same biopsy, everything exactly the same, done in the office, $230, done in the hospital, $1,800. And, the argument there is that the hospital has some facilities and all the requirements of staffing and 24-hour service, and et cetera, et cetera. And so, we're not saying that the cost of doing business at the hospital is exactly the same as in the physician office, but it's certainly not that different, especially when that payment, and I think this is, I'll just throw this in here because it's been one of my fascinations as we go up to DC and talk about this stuff. Mara mentioned the physician fee schedule, and I think the way that's named just sort of implies that whatever that charge is what goes in my pocket. In reality, that's the payment that funds my entire organization, pays my staff, pays my rent, keeps the lights on, in the same way that a hospital would make the argument that they need inflation-adjusted increases every year because rent's going up and employee pay needs to go up and the cost to provide health insurance for your employees is going up 10% every year. And so they've been making that argument and they've been getting those increases, and somehow that hasn't translated over to the physician side, even though it's equally true there.
It's honestly like both of you are in my head because this is exactly where I think I was going to go next. So, the kind of analogy you shared with United is like the way I was thinking about it is you actually can have your cake and eat it too. You can tell the patient the cost of healthcare is going up, so we have to charge you more. And you can tell the doc the cost of healthcare is going up, so we have to pay you less. And that leads to, this ever increasing pie, which is wild. So we talked a little bit about who's paying for it. Let's just say that the U.S. population through the government, patients, private insurance, we're not seeing better outcomes. Now, where is this money going? And I think this is really what you all are alluding to. If we think about the health system, there's hospitals, there's other stuff, there's doctors, there's home health, there's prescriptions, nursing care, et cetera. Where is this money going that continues to go up? I mean, Josh, did you say 10% year over year?
Sure. Yeah. For individual costs
and maybe just to dial it in, is it coming to us?
No. So our proportion, they have some really pretty pie charts that I'd encourage everyone to look at. So the easiest way to look at this is the proportion of CMS's budget that goes to the physician fee schedule. And it is, without a doubt, the smallest portion of CMS's budget. Typically about 7% of the total budget of healthcare cost is paid in payments to doctors for services rendered, basically.
Okay.
So 93% is going elsewhere.
Yeah, that's mind-blowing. So let's dig into this a bit, because I mean, it's embarrassing, but it was also eye-opening, and I'd like to think that I'm not sitting back and doing nothing. The kind of just jaw-dropping shock of being at the AUA Advocacy Summit and what I learned. So let's talk about physician reimbursement. Maybe rewind 20 years ago, we have inflation and we have essentially a conversion factor. And I'll take a stab at this. So maybe in 2001, you did so many RVUs. I think most physicians are familiar with RVUs, and you got paid, let's just call it $50 an RVU. In 2024, you do so many RVUs, and we should talk about whether we're doing more, whether we're doing less, whether we're doing the same. And basically, not to oversimplify, you're still getting paid $50 per RVU. Am I thinking about this correctly? While inflation has increased 3% year over year.
I wish we were getting paid $50 per RVU. I would throw that out there. But so the conversion factor, so it's the schedule is extraordinarily complicated, and you referenced the conversion factor, which you're right, has stayed essentially stable over time. It's actually lower than the conversion factor look at this. So Josh is showing us a chart of the conversion factor and why it's increased, why it hasn't increased. So that's exactly right. It was about $32 when CMS set its first CF factor, and it's about $32 this year in 2024.
There's a great urologist and a name that we should know and respect, Bill G., who was involved in advocacy, maybe kind of the first generation of urologists that really were getting involved in advocacy. And so he lived this, and he said, in the 1990s, the conversion factor is literally the same as it is today. We're getting paid the same amount for work that we did back then, even though we've had such massive inflation since that time. And this is something that, is understood. People will at least now, even in DC, acknowledge how much inflation has impacted our society over the last 20 years, whereas the physician payments haven't changed. The cost to run a practice has gone up. The cost to us as individuals to live life and as a consumer have gone up. And yet the physician payments have stayed the same. And Mara may have been in the same conversation, but we were talking with policymakers in DC, and they like I said, they acknowledged it. They said, we just can't find the money to do anything about it. So they seem to find money for everything else. But
we should be clear, though, the way that these schedules get developed is complicated, and there's something called budget neutrality, which governs some portions. So believe me, I'm willing to assail and assign blame to all of Congress and our legislators and our system. That said, the way that the fee schedule was developed requires that it essentially be budget neutral. So I agree with Josh. This has been challenging, and there has certainly not been the recognition that this is just not a durable mechanism. You cannot run a practice assuming that your costs were to stay the same, that you only needed the same staff or the same technology that you needed, because all of those costs have gone up too in, 30 years ago. But we're dealing with all of the increased costs as well as, just sort of generalized inflation of living our own lives at a essentially stable fee schedule.
Yeah, our message around this is, as we had been talking about with site of service differential and the example, for instance, with the prostate biopsy, is fixing the physician fee schedule and giving us just modest increases with inflation so that we can continue to exist will save the system money in the long run, because you will keep the prostate biopsy at $230 rather than $1,800. And so, as Mara pointed out, it's going to take a major legislative change, and that is a process that takes time. And I had the chance to work up in DC for a while for Bill Cassidy, who's in the Senate, and he's a gastroenterologist, and his wife is a surgeon. And he said, Congress works more at my pace than my wife's pace. And I think as surgeons, we want quick action, we want change. And his point was, medical doctors are used to, let's tweak things a little and see what happens in 6 months. And surgeons don't have that mindset. So it's very frustrating to us, but things in DC definitely don't work at a surgeon's pace.
So, this chart that you have up is pretty wild, where basically physician reimbursement has been flat. I think it's worth highlighting. This is maybe perceived by non-physicians as Mara, Josh, and Aditya are trying to get paid more money in our pockets, but it's really beyond that. It's practice costs, it's overhead, it's staff, it's every bit of it. It's paying for all the regulatory work that continues to grow and grow. One point I also wanted to make is, or question I wanted to ask is, are we doing more? Does a standard urologist do the same number of RVUs? Are they seeing the same number of patients? Are we doing less? I mean, we've ostensibly indexed for inflation, made less, but are we working more or less than we used to a while ago?
So this was a really fascinating point that was brought up at the AUA summit. So across the board within medical specialties, we're seeing an increase in RVUs. So basically everyone within the healthcare system. And by the way, I don't mean just physicians. I mean the APPs, the nurses on the floor. The complexity of patients has increased alongside that. And I think we're all sort of acting like the burnout crisis is unpredictable, or, no one could have called it. But essentially, you're saying that you've got people working harder on more complex patients with massively more complex technology and information. Again, I went to medical school before either one of you. I think I only had to learn 10 medications, aspirin, Tylenol. It's a joke. But nonetheless, the complexity of healthcare and the degree of information that we have at our fingertips, but which we need to sort of cogitate about, that impacts our decision making, the life extending modalities, it's just extraordinary. And we're doing all of that at fewer dollars and more of it. It's extraordinary, really.
Yeah, I mean, if I may just paraphrase, we're working more and getting paid less.
Right, on harder patients.
Yeah, and if you had to probably point to a why does burnout happen, I'm guessing loss of autonomy, working harder, and getting paid less are going to be, front and center as a non-burnout expert. And I mean, Josh, I think you alluded to this, and maybe this is where you're heading. This is like the long game versus the short game. And the short game is let's squeeze as much juice as humanly possible. And that may lead to some access growth benefit in a very short term. But that quickly translates into unsustainability and burnout, where you're like, wait, why am I doing this? This makes no sense at all. So perhaps you can just comment a little bit about that and how that's exacerbating workplace shortages, rural presence, et cetera, and maybe why urology is allegedly the number one most burnt out profession, not just in medicine, across the panel.
Yeah, I think you bring up a great point about how the increased work causes burnout and how burnout impacts the workforce and causes folks to exit the workforce, retire early, look for other types of jobs that they can use their medical degree for, which then simply creates a spiral, right? Because then it puts more work on the remaining individuals who then progressively feel more burnt out and follow the same path. There was a study, I didn't read it, but I heard it quoted, and this seems awfully high, but over half of medical students that were queried said that they were actually looking to do something other than practice clinical medicine. And you could use that to kind of talk about multiple different angles, but I think that, to your point, the reality of clinical practice has become such that people look at it and go, maybe I could try to find something else to do with my time. And we are really in a crisis mode, especially if you start to talk about 5 and 10 year time horizons, where it's a house of cards that could really have some serious ramifications for care in our country if we don't address it.
Yeah. And I guess that's the long game, right? I mean, it's like it's like hiring somebody new in the lab or new in the clinic. You invest in them. You want them to grow, develop. And I think that ultimately pays dividends, importantly, for our patients.
I do think also one other point before, if we're going to move off of payment reform, but the physician fee schedule and the amount paid to doctors for their work may seem less relevant to hospital employed or medical school faculty, but I think it really should matter to all of us because it really represents the value that we are to the organization. So if that number continues to dwindle, then you will be seen by your hospital administrators or your medical school as of lesser and lesser value overall, right? We know the value that we bring, and whatever that practice setting may be. And I think all of us need to be kind of united in this idea that we should fight to have that value represented in the payments that we receive. And that's gonna make a big difference no matter what your practice setting is.
I think that's a really important point, Josh, because again, so we use dollars as a metric for value. That's just the way things work in a society like ours. And if we tacitly accept that our dollar value is going down and yet expect people to understand the innate value or the tremendous value that we bring, we're going to be disappointed every time. And that will impact everyone eventually. The roosters come home.
Yeah, I mean, I was so excited that from our academic department at UC San Diego, there were 4 residents and 3 faculty at the AUA Summit. That is, non-revenue generating time where we're out there for ourselves and for the next generation. But I couldn't agree more. And, honestly, I think my sense is that these kind of artificial divides between practice and academics, scientific, academic researchers and industry, these are all a little bit outdated. And we're really all just trying to take the best care of our patients and of ourselves as well.
Physicians are classically, bad at banding together and making sort of change with one voice. And I think that I've heard us compared to lawyers in that sense, where they're very understanding of the value of the strength in numbers. We're taught, at least historically, if you go back 100 years, you're going to be the only doctor in this town. You have to be completely 100% independent and autonomous. You don't work as part of a team. It's just you. And so that's not, I guess, been the mindset behind other fields. And I think why they've been able to potentially come together and speak as one voice and make sort of policy change in the directions that they want as a result of that. But, I was thinking my clinical practice is men's health, and I do a lot of implant surgery, and kind of behind the curtain, understanding the finances of that operation, I understand just exactly how much money the corporation that makes the implant gains from that procedure. And so I was just, thinking about that, and it's depressing. So try not to do it yourself. But the reality is why. So I'm thinking, why doesn't the government really go after the medical device or pharma? These are easy targets. United Healthcare, we talked about, $20 billion in profit. Well, why are they kind of whittling us down instead of them? And the answer is, my thought is, well, you're not on the S&P 500 and they are. And so if you think about it at the macroeconomic level, any major destabilizing attempt to cut big chunks of profit out of any of these companies, which are all now, most of them, very large, and they're probably very much represented in our grandparents' 401k, that's really not going to go over well politically for a bunch of folks who want to be able to maintain all the right economic metrics so that they get reelected. And so I think that's another sort of underlying theme in why we seem to get nowhere in light of the overall $4.5 trillion spend, right? We just need a very little bit of it.
Yeah, but Josh, I would say, I don't know if it has to be as ominous as you've made it. Certainly those are S&P companies and we're not on the S&P. But fundamentally, I think really you referenced it with the idea that we don't ally together, we don't speak with a single voice, and we don't advocate adequately. So we're so busy taking care of our patients and our mandate as providers of care that we don't stand up and say, our profession needs to be taken care of so that we can continue to induce people to become practitioners so that people will continue to receive care. So again, you referenced those big companies, and what they do have that we don't have besides a ticker is lobbyists. So, LUGPA, it does have lobbyists, AUA does have lobbying, but the involvement of our providers from a financial vantage point tends to be fairly infinitesimal compared to the ability of industry to direct dollars towards lobbying efforts and really get heard by those legislators.
Oh, that's an excellent point. I heard it said that when you combine together all of the other industries of healthcare, besides the physician side, that the combined lobbying is $750 million a year.
Yeah, I mean, even anecdotally, kind of heard it in Washington that, and again, this is not intended to imply anything, that the lobby for nurses, the lobbies for PAs, the lobbies for NPs, which from my vantage point have grown in terms of size and scope and responsibility, is just dwarfs the MD lobby. And I think it's complicated. On the one hand, maybe a cynical view is when you're a practicing provider, at some point, most clinical care becomes straightforward. Seeing patients, you kind of know what to do. There's not a lot of odd situations. Most operations that you do them pretty well. So you can go in and relatively mindlessly occupy your time and make a decent living. And that kind of takes you day to day, that keeps you in the rat race, if you will. But to understand something that certainly wasn't taught to us, I think at least a part of standard medical school curriculum or residency curriculum or fellowship curriculum when I finished up, of how to future-proof your field, that takes effort. It takes acquiring a skill set, and it's harder than just doing what you do. I think research is similar. We can sit back and do what we do in the day-to-day, but to be creative about how to grow a business, do research, future-proof your field, this is just a little bit out of our wheelhouse. And not to mention that's going to be in the short-term money out of your pocket. That's the patient you're not seeing and billing those visits, and those aren't operations that you're doing. So it's again, it's complicated. But yes, I think Mario, you're absolutely right. Time, money. If you can't donate your time, donate your money, and trust that there's people that have your best interests at heart. So the conversation thus far has been a little bit, let's be honest, doom and gloom. Everything's costing more, docs are paying less, outcomes are a little bit crappier for patients. It's not been feel good to me thus far. Super, super eye-opening and invaluable. But what can we do about it? maybe let's talk about some like concrete. So we're not just sitting by as bystander victims. The phrase, if you're not at the table, you're on the menu. How can we actually impact this for ourselves?
So I think the good news is that I love your idea of future-proofing our specialty. All of the residents who I get to interface with are incredibly smart, incredibly enthusiastic, and it's a privilege to be, exposed to their training. We see the developments coming out of industry with devices and with pharma, as well as surgical techniques. So I think those of us who are delivering care and who have been for maybe a decade or so have seen meaningful changes in the therapies that we're able to offer patients, cures that we're able to offer patients. So on, a narrow set of metrics, not sort of a national statistics, but sort of in my clinical practice, I'm able to offer patients things at, sort of lower personal physical cost to them, lower risk surgeries, which are more efficacious. So that's incredibly exciting. The advances in medicine are incredibly exciting. And the kids coming out of training are enthusiastic and skilled, and I probably wouldn't get into residency or certainly through it today. So I think that's all auspicious. I also think that actually, Josh was just up on the Hill, and the conversation on the Hill has finally pivoted despite happening at, that pace that Josh referenced, which is internal medicine / glacial. I've been up there for about 10 years, and typically what fell on deaf ears 10 years ago, now they're saying it to me. They don't know how to fix it. They still don't have the money to fix it. They still don't necessarily have the will to fix it. But the message actually it's gotten through. So actually there's been, I think, a real seed change.
Yeah, I think I've been really lucky to get to kind of come up and be involved in these advocacy efforts. And there have been some really, really impactful conversations and individuals who have given a lot of their time over the years to do this. And to your point, Aditya, I think we just have to really, not everyone has to go, and we're all gifted in different ways. I mean, I know what you do clinically, and it's incredibly complex and difficult. And, so I'm so glad that you're there to do that, because I don't know that I could. But, we all have a different part that we play. I think that where we need, as you mentioned, the awareness and the support from the entire field, because everyone can provide that. And then it does come down to financial support, as you referenced. But I think that we do have a lot of positive momentum in the conversation going on in DC that we hope we can capitalize on and have to keep pushing, as you said, because we really have to be at the table. I think from a workforce standpoint, the AUA and LUGPA and others are very engaged on what the future of the workforce will look like. We know there's not going to be enough MDs. How do we work around that? How do we build systems around the surgeon that'll allow the provision of care to the highest number of patients? And I do think that's one place, as Mara mentioned, earlier, from the independent practice standpoint, we're able to be a little more laser focused on that as a single specialty, do what works for us, be a little more nimble to try things and create systems that will hopefully extend the impact of each doctor that's coming out of training going forward.
Yeah, I mean, in some ways it's intimidating and maybe foreign and distant, but in some ways it's simple. Donate your time, donate your money, tell stories, know your statistics, know your value. I mean, these are things that I really got from some of the resources that Josh shared with me prior to this podcast. And it doesn't need to be that this is your full-time gig. Just finding out who your local state representatives are, sending them some information, patient stories. I think I get the sense that even something that non-time consuming can be impactful.
Actually extraordinarily impactful. All politics is local, right? We spend a lot of time on the Hill and we care about federal policy, but really the most impact we can have is in our local communities.
Yeah, and they do care. They really do. Physicians do still have a position of respect within communities, and so we should use that to make sure we communicate through exactly what impact we are having on communities and on these constituents, right, who are voters. They do want to hear your stories, and they're hearing about such an incredibly broad array of different topics that you might think to yourself, why do I have to go and have this conversation again or go back year after year? But you really have to be persistent with these messages to really hammer home the perspectives And, staff changes, things change, they need to hear it again, momentum builds gradually. And so it is still effective, and it is the way that change happens, even though, again, it doesn't really necessarily fit with our surgeon pace of life.
Well, Josh, Mara, I've learned a ton, as I knew I would. I leave hopeful, not hopeless. And I feel like we could continue to talk for another hour, but maybe as we're wrapping up, I'd like to hear some just kind of parting thoughts from both of you.
I think the only thing I would say is, you referenced not everybody has to be involved, donate money, donate time. Also, Aditya, you made a really great comment about how you get pretty good within your wheelhouse at your clinical skills. The first 3 to 5 years you're out, you're busy figuring things out. You're probably going to be overwhelmed by the idea of needing to be involved in advocacy and politics. Not necessarily, but I certainly was. So this is not necessarily something you will intersect with at every point in your career. But, the idea is that the degree to which you may be involved and how you may be involved and the opportunity to be involved may change at year 5, year 10, year 15, as well as, sort of what you can offer to the conversation over that time. So really encouraging people not to sort of, decide to go all or none. This is really something you can kind of come and go from.
Love that.
And that was what I was going to say. So now I have to think of something else. But I think, along those lines, it's really about the next generation. All these conversations are looking to the future, including who are going to be the next generation of physician leaders and advocates. And so kind of circling back to where I started, if there are folks out there who do have an interest, not even just in the policy or political side, but also leadership, don't feel like that is antithetical to your role as a physician or as a surgeon, as a urologist. We need folks who can do both, can live in both worlds, speak both languages, if we are going to maybe take back what we once had. I mean, as I was talking to an older surgeon, and he said in his training and early career, hospitals were run by doctors, and that went away at some point, and probably to the detriment of our patients at the end of the day, right? And so if we are going to regain a voice really in the national conversation, it's going to take individuals understanding that if they have that interest, that's okay and that's good, that's necessary. And I think Mara said very nicely, is probably going to happen in phases throughout their career, but we definitely want to support that. And if there's anything we can do individually or as an organization to bring people along, we want to be doing that.
Also, I'd love to make a plug for the AUA advocacy meetings, the LUGPA advocacy meetings, the AUA advocacy meetings and the LUGPA advocacy meetings. Those are really tremendous resources, and the material that's presented is eye-opening and pretty impactful. So please, those of you who can participate in those, or even just review the materials, which are generally made available online.
Yeah, great point. We actually really want people that haven't done it before, and it's not an intimidating thing to do. We want folks to come up and just see, even if it's just one time, what it's really like to do that kind of advocacy work. So please don't be intimidated by it. We'd love to have you at any of those.
I couldn't agree more. It was my first meeting this past February in DC, and I felt it was awesome. I learned so much, is empowering, and I'm incredibly grateful for the people that have made this front and center as a part of their livelihood and their careers. Josh, Mara, it was absolutely a pleasure having you on. Thank you so much for your intel today and for everything that you do. And I'm sure we'll be reconnecting in the future.
Thank you.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Devante Delbrun.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.